بسم الله الرحمن الرحيم. اوكي كده. Everyone is hearing? Okay. Sorry for being late for some technical problems. Good afternoon, everyone. The title of my talk today is Assessment of LV Diastolic Function. If anyone actually looked at any echocardiography report, or most of the echocardiography reports in our daily clinical practice, we find that the function is not properly assessed. And this is very important because it has an implication on the diagnosis of many important diseases, especially heart failure. Most of the information in this presentation rely on the latest recommendations and update of from the European Association of Cardiovascular Imaging and the American Society of Echocardiography. It's published in 2016, and actually I advise you to have a look on it and to read it carefully. It's really very. We know that there are 4 phases of diastole, started by the isovolumic relaxation phase, and then there are 2 filling phases, the rapid filling phase followed by the slow filling phase, and the 4th phase is the atrial contraction. It's evident here, patients, if he has a normal end diastolic pressure, but here the pressure volume loop that show high end diastolic pressure. Diastole, as we know, it's not a passive process. It's not related only to the passive properties of the left ventricle, but also it's an active process. It depends, the process of relaxation is an active process. It depends on the rate of calcium uptake from the cytoplasm after systole to the sarcoplasmic reticulum, and also outside through the sodium calcium exchange. So if the relaxation process is impaired, or if there is an increase in the interstitial fibrosis and increase the stiffness and decrease the compliance of the ventricle, all this lead to progressive diastolic dysfunction. As I said before, that most of the echocardiography reports rely on only a single variable or index to assess the diastolic function, mainly the mitral inflow velocities, which we will see later on in my presentation that it is not valid actually in all patients, and it's very important not to rely on a single variable or single index to assess the diastolic function. There are many actually indices that can be used. Firstly, some structural and morphological factors like the left atrial size, the left ventricle hypertrophy, and then we have the mitral velocities, tissue Doppler, the color flow propagation, and also the pulmonary venous velocities, and on the right side, the tricuspid regurg jet velocity. All these variables is very important in assessment of the LV diastolic function, and we should not use a single index. Usually, consistency of more than 2 or more of these indices is important to diagnose LV diastolic dysfunction. Let's start by the mitral inflow, which is the most famous one. The mitral inflow is measured, as we know, in the apical 4-chamber view by putting the sample volume. It's a pulsed Doppler on the tip of the mitral valve, and we'll here appreciate the normal EA waves. The E, we measure the E velocity and the A velocity. The E, which is reflects the filling, the passive filling of the ventricle, and the A, it represents the atrial contraction. And with progressive diastolic dysfunction, firstly in what's called grade 1 or impaired relaxation, there is reversible EA ratio. So here, this is the E wave and this is the A wave. So the EA ratio is reversed, the E velocity increases significantly. And then in the grade 2, or what's called normalization pattern, we like actually it's quite similar, the EA, but maybe the A is increased a little bit and became close to the E. But here we need some tips to know whether it's normal or it's pseudo-normal. It's a grade 2 diastolic dysfunction, mainly by asking the patient to hold his breath in a forced expiration Valsalva and record it for 10 seconds and see how it will behave. We'll find that this Valsalva, the wave increased, and then it changed to reverse EA ratio. So this means that once with Valsalva and with decrease the preload on the left ventricle, evident diastolic dysfunction occur. But we have actually other variables that can be used like tissue Doppler, and I will clarify this later on to confirm the presence of diastolic dysfunction. With grade 3 or restrictive filling, the EE ratio actually increased more than 2. So the ratio here increased significantly. So this means a grade 3 diastolic dysfunction. But importantly, there is very, very important limitations in assessment of the diastolic function by the mitral inflow velocities alone. Because in patients with coronary artery disease and thus with normal ejection fraction, the mitral inflow velocities correlate poorly with the LV filling pressure, which means that actually in our daily clinical practice, actually most of the echocardiography reports, patients are normal ejection fraction, have some hypertrophy, some has coronary artery disease. So mitral inflow velocities are not reliable to use it alone to assess the diastolic function in those patients. But it is reliable and it correlates better with the LV filling pressures in patients with dilated cardiomyopathy and with reduced ejection fraction. So it is reliable in patients with reduced ejection fraction, but it is not reliable and it correlates poorly with the LV filling pressures in patients with normal ejection fraction and left ventricular hypertrophy. It is also age dependent, and we know that with increasing age, actually, the E velocity increase, normal to find reversal E ratio and the grade 2 even diastolic dysfunction in patients, in elderly patients. That's why, actually, if we assessing the diastolic function in patients with normal ejection fraction, we do not rely on the mitral inflow velocity. And we have very important 4 variables to diagnose diastolic dysfunction in those patients. The first one is the E prime ratio, which is the ratio between the mitral E velocity and the E prime by assessing the annular velocity, either the lateral or the septal. So if we take the average and it's more than 14, this is 1 point. The second one is just the absolute value of the lateral or the E prime velocity. If the lateral E prime velocity less than 10, or if the septal E prime velocity less than 7, so this is the second point. The third one is the tricuspid regurg velocity more than 2.8, and the fourth one is dilated left atrium, and they do not use actually the left atrium anteroposterior diameter, but they use the left atrial volume index more than 34. If we have 3 among of these 4, so this patient definitely have diastolic dysfunction. If you have 2, so it is indeterminate. So it's not sure that you have diastolic function or not. Here, if you couldn't assess both the lateral and septal, so if they use only the lateral, so the value will become 13. If you use the septal, so the value will be 15. So in patients with normal ejection fraction, it's very important to combine the mitral inflow velocities with the tissue Doppler annular mitral annular velocity and measure the lateral E prime and the septal E prime velocities and take the average E prime velocity. So this is important, but still the tissue Doppler derived mitral annular early diastolic velocity, the E prime, has some limitations, specifically if the patient has prosthetic mitral valve, surgical ring, status post mitral valve repair, and there is ring in the mitral annulus. if there is a significant mitral annular calcification, if the patient has coronary artery disease and regional dysfunction in the basal segment related to this annulus. So all this will not give you a correct or a true annular velocity that you can use it to diagnose diastolic dysfunction. Also, still, it's an age dependent process. So with age, also the annular E prime velocity decrease. And importantly, it's also a load dependent. So it depends on the volume status and the loading status for the left ventricle. Also, if the E prime ratio is ranging between 8 and 14, we know that the normal is below 8. So if it's ranging between 8 and 14, this does not mean that the patient has normal filling pressure, but you need other tools to confirm if he has diastolic dysfunction or not. So just to repeat, it's very important. There are 4 variables that you can use to assess the diastolic function in patients with normal ejection fraction. You need 3 among these 4 to surely diagnose diastolic dysfunction. And if you have 2, so it is indeterminate, and you may use other tool, as I will highlight later on. This is an example for the septal tricuspid annular velocity. Here, the S prime, this is a systolic, and this is the E, the early diastolic and late diastolic. So this is the E prime and the A prime. So you measure here the E prime velocity either in the septal and also in the lateral annulus. Importantly, you should do it carefully to be sure that the sample volume in the accurate annulus. So here it's correct, but here it's actually outside the heart. Here it's in the left atrium. Here it's just low. So it's very important to have an accurate E prime to get a good apical 4-chamber view, identify the annulus properly, and put the sample volume, and also decrease the sector widths help a lot to get an optimum annular E prime velocity. Tricuspid regurg velocity is very important because patients with diastolic dysfunction have a high pulmonary wedge pressure and have some pulmonary hypertension. So the tricuspid regurg velocity, if it's more than 2.8, so this gives you an indicator that this patient may have a diastolic dysfunction. So this is one among the 4 variables that I highlighted before. Left atrium size, you know that all our echocardiographic reports rely on the anteroposterior diameter, but sometimes the left atrium dilated in other directions. So the guidelines recommend the use of the left atrial volume index if it's more than 35. So this also support the presence of diastolic dysfunction. We need to know that sometimes left atrial dilation occur even in normal patients in the presence of bradycardia in well-trained athletes with bradycardia and well hydrated. So left atrium can be normally dilated even without any pathology in the heart. The high cardiac output status, patients with AF have some dilation of the atrium, and definitely patients with mitral valve disease may have left atrial dilation without LV diastolic dysfunction. If we look at the diagnostic algorithm and the score to diagnose heart failure with preserved ejection fraction, you will find also it's quite similar to the proposed criteria from the echocardiography report. So to diagnose heart failure with preserved ejection fraction, you need 5 points or more. If you have 2 to 4 points, so you may need to exercise the patient or do some stress to diagnose LV diastolic dysfunction. The HFpEF score has 3 domains: functional, morphological, and biomarkers. Functional, as we said before, it's actually quite similar numbers. If the average E prime velocity 15 or more than 14, so this is a major criteria. If the septal E prime less than 7 and lateral E prime less than 10, so it's major criteria, and every major criteria take 2 points. The tricuspid regurg velocity more than 2.8, also it's take 2 points. If the average EE prime velocity borderline between 8 and 14, so it take only 1 point, so it's a minor criteria. But importantly, here in this report, they clarified that this is valid for patients aged less than 75. But if the patient aged 75 years or more, so the value, it becomes less. So the S prime velocity should be less than 5 to be considered a major criteria, and the lateral E prime velocity should be less than 7 to be considered as a major criteria in patients aged more than 75, because we are expected, and actually all this are age dependent, and actually all this velocity decrease with age. The second domain is the morphological domain, which reflects the morphology of the heart. The left atrial volume index, if it's more than 35, it's quite similar to before, and the left volume mass index, if it's significantly hypertrophied in males, if it's more than 149 in women, if it's more than 122, so it's a major criteria. If it's more than 115 in males, so it is minor criteria, and in women, if it's more than 95, it's considered minor criteria, and it received 1 criteria. But importantly here, in this score, they changed the cutoff value for the left atrial volume index in patients with AF. So this is valid if the patient has sinus rhythm. But if the patient has atrial fibrillation, the left atrial volume index should be more than 40 to be a major criteria and receive 2, and a minor criteria between 34 and 40. This is very important because it's expected that the left atrium dilate in patients with AF even in absence of diastolic dysfunction. The third domain is the biomarkers, and there is different cutoff values between sinus and AF. The cutoff value for internal proBNP in sinus is 220, and in AF is 660. So the score proposed to diagnose heart failure with preserved ejection fraction is quite similar to the algorithm proposed by the American Society of Echo and the European Association of Cardiovascular Imaging to diagnose diastolic dysfunction in patients with normal ejection fraction. And as you see here, there is no place for the mitral inflow velocities and grade 1 and grade 2 and grade 3, and the ratio between and the EA velocity does not have place here in patients with normal ejection fraction, but it will be used in patients with reduced ejection fraction. If the score here between 2 and 4, so you may stress the patients and do stress echo. And if the EE prime velocity jumped to 15 or more, or the TR velocity increased more than 3.4 meters per second, so this actually can take 2 points, and this can diagnose diastolic dysfunction if the patient is dyspneic and you don't find any reason why he is dyspneic. And the score for diagnosing HFpEF is between 2 and 4 and does not fulfill the criteria, so you may stress the patient to see if they have really diastolic dysfunction and HFpEF or not. What about patients with reduced ejection fraction? Here, you assess the mitral inflow velocity. You see the ratio. If there's a grade 3 diastolic dysfunction, and definitely the left atrial pressure is high, so this is a grade 3 diastolic dysfunction in patients with reduced ejection fraction. If the ratio is 0.8 or less, and the E velocity is less than 50 centimeters per second, so this is normal, or may have a grade 1 diastolic dysfunction. If the numbers in between, so if the patient, if the EA velocity 0.8 or less, and the E velocity is more than 50, or if the EA ratio between 0.8 and 2, so you depend on other criteria, which is actually quite similar to the criteria we used in the patients with normal ejection fraction. The average EE ratio, EE prime ratio more than 14, the tricuspid rigorous velocity, and the left atrial volume index. If the patient has 2 among 2 of 3, so this patient definitely has a grade 2 diastolic dysfunction and the left atrial pressure is high. If it's only 1 positive, so it's indeterminate and you cannot prove that the patient has diastolic dysfunction. This is the usual indices that can be used to diagnose diastolic dysfunction. But there is other variables that can be helpful, specifically if the patient has indeterminate values, which is a pulmonary venous flow. Pulmonary venous flow, it's very easy. In the apical four chamber, you get a good apical four chamber and put the sample volume in the right upper pulmonary vein, within the pulmonary vein, and see the S here. You have the S, this is a systolic, and this is a diastolic. So this is S, D, and this is the atrial reversal, the reversal of flow that happened from the left atrium to the pulmonary veins during the atrial contraction. Okay, you can depend on the SD ratio, but the most specific variable among all the pulmonary venous flow variable that can be used to diagnose diastolic dysfunction is the difference between the atrial reversal duration and the A velocity duration. So you measure the duration of the A wave in the normal mitral inflow, and you measure the duration of the atrial reversal wave in the pulmonary venous flow. And if the atrial reversal wave duration exceeds this by 30 milliseconds or more, so this is actually suggests the presence of elevated left ventricle end diastolic pressure and diastolic dysfunction. Look at here in this example, this patient, this is the EA, this is a mitral inflow. The duration of the A wave was 125, and here the atrial reversal duration is 165. So it's more than 30 milliseconds, and this patient has a high LV and diastolic pressure, which means that just you imagine it clinically, if the patient has a high LV and diastolic pressure, so during atrial contraction, the flow will be directed toward the pulmonary veins, and the duration of flow back to the pulmonary veins will exceed the duration of the flow that will occur through the normal mitral valve in patients with high LV and diastolic pressure. There is also other variables like the color M mode flow propagation velocity. In the apical four chamber, you put the color and you put M mode across it. So this is color M mode. And here you measure the slope from here the mitral valve to 4 centimeters later on, and you will see this slope, and they divide actually the mitral E velocity by this flow, the color flow propagation velocity, and it could be an indicator, but actually we don't use this actually in our clinical practice. So if the ratio between the mitral E velocity and the color M mode flow propagation velocity 2.5 or more, this predict a high pulmonary wedge pressure. All these variables can be used in patients with indeterminate LV diastolic dysfunction if it's not clear by the usual variables. So you may use additional variables to know whether the patient has significant LV diastolic dysfunction or not. The duration of the isovolumic relaxation time also can be used in the apical chamber view. If you put the pulsed wave between the mitral and the aortic, so you will get the aortic and the mitral spectral Doppler waveform in the same on the same time, and you can measure the isovolumic relaxation time duration. And also you may divide this by other variable, which is the time to E divided by the time to E prime. So if you just measure the time from the R wave to the E wave and the time between the R wave, so you should be ECG gated, to the E prime velocity, actually it's really very complex. And if the ratio is below 10, so it has high accuracy for diagnosing also LV filling pressures. All this actually measures present in you can use it to more and more deeply assess the diastolic dysfunction, but I ask you mainly to depend at least for the common variables, the 4 variables that we highlighted in patients with normal ejection fraction, and also the three variables in addition to the mitral inflow velocities in patients with reduced ejection fraction. In special scenarios, actually, it's difficult sometimes to assess the diastolic dysfunction, especially in atrial fibrillation. You know that the cycle length is variable, so sometimes it's you find a variable E velocity and variable E prime velocity, but the recommendations in this report is to use the septal E prime velocity if it's 11 or more, in addition to the ratio between the E and the color flow propagation velocity if it's more than 1.4. If you can measure here the isovolumic relaxation time if it's less than 65 milliseconds. So this actually guides and increase the possibility of having LV diastolic dysfunction. Finally, I will just in this slide see how to compare between constrictive pericarditis and restrictive cardiomyopathy. Both are restrictive, represent the restrictive heart syndrome, and sometimes it's difficult to differentiate, but actually if you looked at carefully, it will be easily to identify the cause of the restrictive heart syndrome by echocardiography. Firstly, you just have a high index of suspicion if you find the patient with dilated IVC and have some diastolic dysfunction and the EA velocity more than 0.8. So this increases the possibility why this patient has high right atrial pressure. So firstly, look at the ventricular septum. If you have an abnormal septal motion, what's called septal bounce, so this favor more constrictive pericarditis. And then the most important is the medial E prime velocity, because in patients with constrictive pericarditis, the medial E prime velocity is preserved. In constriction, this affects and it can decrease the lateral E prime velocity, the annular velocity, the lateral, but the mitral will be preserved. So if it's more than 8, so definitely this is a constrictive pericarditis. But in patients with restrictive cardiomyopathy, both the medial and lateral will be affected. So if it's less than 6, so this favor more restrictive cardiomyopathy. If it's between, so sometimes it's mixed. Sometimes you need to assess, for example, the hepatic venous flow and see if there is an expiratory reversal of flow, which happen in patients with constrictive pericarditis. Just this slide to highlight the importance of the medial mitral E prime velocity rather than the lateral in patients with constrictive pericarditis. Thank you, and by the end of this presentation, I'm willing to answer if there is any questions. I hope I tried to make it simple and to remember some algorithms and some criteria that help to accurately assess the diastolic function in patients with either normal or reduced ejection fraction. حد هنا عنده سؤال مبدئيا؟ Anyone actually? I think it's. Let's see if there's any questions from the audience through the Zoom meeting. We can receive even questions in the chat. If anyone has questions, he can write it and we can answer him. Any questions? أي أسئلة بالعربي؟ So thank you all, and inshallah we will have a daily, I think it's weekly. Every other week there is a lecture in the ECHO course, and I hope you get all the information that you need. Thank you, everyone.